We're going to go ahead and get started because we have such an exciting day planned. And as everyone knows, Grand Rounds, when we have a CPC discussion, is my absolute favorite. It's always a privilege to hear someone going through their diagnostic reasoning, walking through a case, and then figure out if they get it right or not. Not the purpose. So today we are very fortunate. Chris Young, our chief resident, has put together a really interesting patient story for us. And then Danielle Johnson is going to walk us through her clinical reasoning as she approached this patient. As many of you know, Danny has been at VCU for quite some time. Danny is a graduate of Northeastern University, which we were just talking about, one of my favorite universities in the Northeast. She then came here for medical school and stayed on for residency. Thank goodness, because I was advising her. And at that point in time, I made her go interview at other places. I don't know what I was thinking. I do remember when she and her significant other went to look at other places, I thought, what am I thinking? We don't want to lose this young lady. Thank goodness she stayed with us for residency, and then we're very fortunate that we never lost her. It was a privilege to have her stay on as a chief resident. And as many people know, Danny ran the residency that year that she was a chief resident, and I just reported to her. She is an excellent clinician. She is a really talented educator. She's developed an interest in medical education, curriculum development, and she, again, agreed to stay on, and she is now a junior faculty member in the Division of General Medicine, where many of our learners get to interact with her, both in the ambulatory and in the inpatient setting. So it's such a privilege to have Danny on faculty, and it's going to be a great experience listening to her walk us through this patient story. Chris is going to come up first, walk us through the story, then we're going to hear from our favorite radiologist, Avi, who's going to go over some of the X-ray findings, and then Danny will come up and go through her talk. Chris?
Thank you, Dr. Cole. I'm going to go ahead and begin with our patient story. So we are going to give you a patient, a 68-year-old female with a history of recently diagnosed spindle cell sarcoma of the liver in her usual state of health until 3 months ago, when she began developing chills, fatigue, lightheadedness, and dyspnea. She went to her physician, was prescribed doxycycline and prednisone for 5 days, and was diagnosed with an asthma exacerbation. This was 1 month ago. Mild improvement on that treatment. 1 week ago, she developed recurrent dyspnea with non-productive cough and began a 5-day course of azithromycin. Her dyspnea became constant 3 days ago, worsened with exertion, and she developed a pruritic, painless rash on her bilateral forearms. At that point, she stopped all medications, and the rash spread to the trunk, lips, and mouth. On arrival to the hospital, she developed marked respiratory distress, was unable to speak in complete sentences, and was intubated and placed on mechanical ventilation. She gave us further history of 1 month of painful mouth sores, mild odynophagia, 1 month of abdominal pain, swelling, and loose stools, and a month of poor appetite with no weight changes. Review of systems was notable for no hematuria, no hemoptysis, no chest pain or palpitations, no vision changes, but did endorse a grit sensation in her eyes. She does endorse early satiety, no recent travel, and had a positive sick contact with a grandchild. Past medical history notable for asthma, hypertension, spindle cell sarcoma of the liver, as mentioned, recently diagnosed. Family history notable for a sister with multiple sclerosis, but no history of malignancy, pulmonary disease, or metabolic disease. She's allergic to loratadine and gadolinium, and her medications, as you can see, albuterol, metoprolol, nifedipine, extended release, and turmeric supplements. She lives in Lynchburg, works as a delivery driver for DoorDash, no past or present tobacco use, no alcohol or other drug use. She eats a normal American diet, is married and monogamous with her husband, and has no recent travel outside the United States. Her physical exam on presentation, which is a temperature of 36.7, blood pressure of 142/58, a heart rate of 94, respiratory rate of 20, and her oxygen saturation is 93% on ambient air. So it's a BMI of 32. She appears stated age, well-nourished, alert, but in moderate distress, and then worsened. Her head and neck exam, notable for upper and lower lips with purple discoloration and multiple small ulcerations on her upper and lower lips as well, with whitish erosions in the oral mucosa. Her eye examination was remarkable for bilateral erythema with edema and hardening of the skin, bilateral trace injection and scant clear discharge, and her corneal exam showed inferior punctate epithelial defects. Cardiovascular exam, she was tachycardic with irregular rhythm, also had 3+ pitting edema to her mid-shins. In her lungs, she was in moderate distress, able to speak about 3 words, had minimal bilateral air movement with scant end expiratory wheezing, with no stridor, rales, bronchi, anything else. Her abdominal exam, she was soft, obese abdomen, no hepatomegaly noted, but marked fullness in the right upper quadrant. She had no splenomegaly, no fluid wave, present bowel sounds, no appreciable lymphadenopathy, no evidence of muscle wasting or arthropathies. Her dermatologic exam, she had numerous non-tender pruritic thin papules and plaques covering diffusely across extremities and torso, were more prominent on lower extremities than upper extremities, non-blanching, many with overlying scaling. She had maceration of the right posterior thigh about the ischial tuberosity and negative Nikolsky sign. She did have scaling noted on her scalp, an unremarkable neuro exam. These are the images, a few of the images of the rash. Her laboratory studies, she had a basic metabolic panel notable for a bicarbonate of 37, creatinine of 0.64, her liver panel an albumin of 3.6, alk phos of 386, her CBC, a white count of 11.8 with a relatively normal differential, neutrophils of 10.6. Urinalysis notable for large blood, specific gravity of 1.027, greater than 100 red blood cells and 11 white cells. Other serum studies, she had a Hep B surface antibody positive, anti-dsDNA positive, negative ANA and SSA and SSB, and a low C4 at 8 milligrams per deciliter. Her arterial blood gas, 7.15, 144, and 120 on 6 liters of nasal cannula oxygen. Her imaging, she had a right upper quadrant ultrasound with a large heterogeneous mass, the known mass, and a CT chest with contrast with background mosaic attenuation, parenchymal pattern consistent with underlying small airway disease, mild vascular engorgement, and volume loss and airspace consolidation in the right middle lobe and both lower lobes. I will now give the floor to Avi Palutla, our expert radiology discussant.
All right, hey guys, can you hear me?
We can hear you, Avi.
Excellent, excellent. Can you guys see that PowerPoint up? All right. Very good. I'm assuming that this PowerPoint is up, so I'm just going to go ahead and start talking here. Thank you for having me, everybody. I have both the chest CT and CT abdomen and pelvis findings, so let's just go ahead and jump right in. So this is, the first is going through from the chest down into the abdomen. So what I have here is 2 axial CT images of the chest. These are 2 different patients. This one right here is a normal patient for comparison, and this one here is our patient in question. So the reason I wanted to bring up the normal patient in question was because I want to discuss the normal appearing lung parenchyma. So what we should expect to see is a very nicely homogeneous lung parenchyma, low attenuation, and we're supposed to be seeing vessels throughout, and those vessels will normally taper as they get out to the periphery. And once you get to the periphery, you're basically not going to see any vessels almost touching the subpleural region. So all of this is normal findings, and you can see the oblique fissure here coming through in the axial. In our patient, on the other hand, we don't see a homogeneous low attenuation. What we see is areas of increased attenuation interspersed with areas of low attenuation. Again, here's an example of increased attenuation. Here's an example of low attenuation. Same thing here, high attenuation and then lower attenuation. And normally when you first see this, the first thing that we would be thinking about is ground glass opacification. It's central in distribution in this case. We would be thinking about edema, we would be thinking about infection, or we would be thinking about hemorrhage. However, in this case, what we're seeing is in careful review of the areas of low attenuation, we're also seeing some associated oligemia. When we think about that, we think about 2 things. It's a finding that we call mosaic attenuation or mosaic perfusion. This leads us down the pathway of small airway disease or small vessel disease. And in order to differentiate those 2 even better, you have to look at the secondary findings. And the secondary findings here, I think that are prominent or important are some of the airway thickening that we see here, for example, in some of the smaller airways, which we don't see in the comparison image. So if I was to put all of these findings together, this is more in line with mosaic attenuation, related to a small airway disease. So I think that's one of the most pertinent findings here. Moving on, there are a few other things I want to discuss. So these are sagittal images of the lungs. We have the left lung here, we have the right lung here, left upper, left lower lobes, right upper, right lower, right middle lobes. And we can see how the right middle lobe is almost completely collapsed, just a little bit left here due to atelectasis. And there's also volume loss in the right lower lobe and volume loss in the left lower lobe. Obviously, whenever you think about volume loss and consolidation, one of the things you do have to think about is underlying infection. Going to the next images, we have a coronal CT image of the chest here, and then a axial CT image of the chest here. I bring this up because I want to show that there is an enlarged heart. We have trace to small pleural effusions bilaterally, and then we have right hemidiaphragmatic elevation. Now this is kind of nonspecific, and we don't have any comparison images, but right hemidiaphragmatic elevation can be due to multiple things. You can think about trauma, you can think about nerve injury, you can think about eventration or thinning of the diaphragm, but that's also there. And then now moving more into the CT abdomen images, again, I've got our patient's abdomen here and then a comparison abdomen for reference. So looking in the comparison abdomen, what we're seeing here is just reviewing the normal anatomy, the liver, the gallbladder here. Here's the extrahepatic biliary tree. This is probably the common hepatic duct coming to hook up with the common bile duct. The pancreas here, the duodenum, the stomach. Here's the portal system, the superior mesenteric vein, and probably a left portal vein here, I would say. So in our patient, what we're seeing is this very large inferior hepatic mass. It's arising from the liver, and it's enhancing higher than the liver, and it also has a heterogeneous enhancement pattern with areas of low attenuation centrally, which can be thought of as central necrosis. It's also very large and causing a lot of mass effect, so much so that if you look at the duodenum, normally it's supposed to take a curve to the left like that. Here, it's actually taking the opposite curve. And then looking at the gallbladder is significantly distended. The cystic duct is significantly distended. You've got intrahepatic biliary ductal dilatation. Note there are no bile ducts that can be seen out here. And then the common hepatic duct is very distended. And then you don't even see the common bile duct at all. And that's probably the source of biliary tree extrinsic compression. And then there's also a little bit of free fluid that we see in the right paracolic gutter. So moving on, there's a few non-specific findings for completeness sake. Anytime we have a mass that we're looking at, we have to think about nodules. So there were 2 tiny pulmonary nodules. There are osseous sclerotic foci scattered among the vertebral bodies. Here's one right here in the T1 vertebral body. Again, non-specific, it could be a bone island, but has to be considered. And then scattered sub-centimeter non-enlarged lymph nodes. Here are a couple here in the chest in the AP window that are small and non-enlarged, could be reactive. So putting all of the findings together, we've got a large centrally necrotic inferior hepatic mass with significant local mass effect. We've got pulmonary parenchymal features that are suggestive of underlying small airway disease. We've got bilateral lower lung consolidated volume loss. There's severe biliary obstruction. There is a mild volume overload state on imaging. And then non-specific findings of pulmonary nodules, osseous sclerotic foci, and scattered sub-centimeter non-enlarged lymph nodes. And I'd be happy to take any questions, and thank you for listening.
Thank you, Dr. Palutla. We really appreciate it. It's now my honor to give the floor to Dr. Danielle Johnson, our case discussant.
Hi, everyone. I'm Dani Johnson, if you don't know who I am. And I'm really excited to be here today to talk about this 68-year-old woman that's presenting with progressive dyspnea and a rash. I have no disclosures, I wish. So my objectives today, talking with you, I want to demonstrate clinical reasoning using this case. I also am going to describe, and hopefully you all appreciate, the dichotomy of thought modes that are commonly involved in clinical reasoning. And then we're going to review, and you'll hopefully recognize some sources of cognitive bias or heuristics that happen in the clinical reasoning process. So before we begin, we're all going to get a quick review. And what are we reviewing? We're going to review the dichotomy of thought modes. So system 1 versus system 2 thinking. There's no CPC that doesn't address this. So system 1, what is that? That's what I like to think of as kind of the light bulb, the instantaneous thought, the pattern recognition. This is very underdeveloped in young trainees. Not that I'm an old trainee, but I feel like mine's moderately developed. But medical students, they have very little system 1 thinking because it's pattern recognition. They haven't been around very much to see many of those patterns. So they'll rely on the other system, which I'll talk about in a second. But as you develop in your clinical career, you see more and more presentations of common states, uncommon states, atypical presentations, typical presentations, and you start building these patterns that you can then quickly recognize when things fit or don't fit with that. Contrast that to system 2, which I like to think this happens inside my brain when I think about patients, is lots of filing cabinets. Things are very organized in this way. It's tucked away. It's an organized thing that you can go to the correct file and pull out exactly what you're looking for. This obviously would be very time consuming. This takes a lot of energy. It can be exhausting. There are some literature that suggests that we spend 95% of our time in type 1 thinking or system 1 thinking. And that's because of this. It takes a long time to sift through all those files in your brain. So medical students spend a lot of time here, and that's why maybe it takes them a while to come up with some differentials and things like that. But it is very important that we do recognize both systems in our thinking. System 1 is quick. It's instantaneous. It's the light bulb going on. That's great. It saves us a lot of time, but sometimes we miss things. And so that's why we have to slow it down sometimes for system 2 and really be methodical in our approach. And I've never thought this even more about a case than this one. And you'll see why in a minute. So we're going to start thinking through this case. And I'm going to take you exactly through my thought process, what happened when I got this case several weeks ago. So first, we're going to go back to the case. I'm going to go through the history, the exam, the labs, and diagnostics. I'm not going to read all this. Chris just did that. But I want to share with you the things that really kind of jumped off the page for me when I was looking through this patient. So everything highlighted in red here stood out. She was short of breath. She had these kind of constitutional symptoms, fatigue, lightheadedness. There were drugs involved. This dyspnea kept coming back. More drugs were involved. She got a rash. She then developed pretty significant respiratory distress on arrival to the hospital. So much so that she required intubation. These mouth sores and odynophagia, can't ignore those. And then she had a lot of nonspecific GI findings, some pain, some swelling, loose stools without diarrhea. And importantly, she really didn't have much in the way of exposures to things. She had no tobacco use, no travel. There was this questionable grandchild sick contact, but she didn't have any fevers or anything that kind of screamed infection. And so in my brain, these things started to get reorganized, and I came up with some systems that we think were involved. So obviously the pulmonary system must be involved. This lady was intubated. But we have to consider medications and what their impact might have on our differential. Her skin was certainly involved, as you saw in those pictures. And she had pretty diffuse GI involvement, going all the way from mouth sores to pain to loose stools, so kind of throughout the GI tract. Moving on to the exam. Again, I'm not going to read all this. Chris just did that and did it beautifully. But we're just going to highlight a couple of things, like I said, that really stood out as key features to the case when I first went through this. So her vital signs, obviously abnormal. She has a heart rate of 94. She's tachypnic. She's hypoxic on room air. Her eyes had injection. Her cornea had inferior punctate epithelial defects. That sounds really important. I'll have to look that up. Her mouth had this, with the way that I got the case said, it was hemorrhagic crusting of her upper and lower lips. And you guys mentioned there was some small ulcers on her lips. And she had erosions on her buccal mucosa going along with her reported history of mouth sores. On cardiovascular exam, interestingly, she had all this edema, but there was no JVD. And then on her respiratory exam, very important, obviously, she ended up intubated. She had minimal air movement. It sounded like pretty significant respiratory distress. Her abdominal exam, sounds like it was probably all this cancer, just this fullness in her abdomen, distended, but no fluid wave. Completely normal neuro exam, interestingly. And her skin, we saw the pictures, very significant papules, plaques, purpura everywhere, some maceration of her skin, this negative Nikolsky sign, and interestingly, no vaginal involvement with the rash. So the extra system that we found here is ocular involvement. So let's move on to the labs and diagnostics. Again, I'm not going to read all these things out, but I'm just going to show you what stood out to me. So on her chemistries, the bicarb was high, definitely stood out to me right away. On her CBC with differential, there was no anemia, interestingly, and a little bit of a left shift, but not really a leukocytosis. She just had predominant neutrophils in her diff. Her liver chemistries showed a biliary pattern predominantly, a little bit of AST, ALT elevation, which I'm just assuming is from this massive cancer that we just saw in her abdomen. Her urinalysis had some blood, but only small protein. The rest of her chemistries showed that she was Hep B immune. There's positive double-stranded DNA, and complements, I had to look up what the normal values for complements were. It sounds like Chris told us at least her C4 was low. I think her C3 might have been a little low too. Her ABG obviously had that CO2 of 144, so she's got a respiratory acidosis, and she's hypoxic. She's on 6 liters. So the other imaging, the right upper quadrant, I'm not super impressed. It's probably just this liver mass that we already knew that she had this spindle cell cancer. And then her CT chest, Avi did a lovely job describing all that. The things that stood out to me was this volume loss and consolidation, infection, not infection, this mosaic attenuation, love those buzzwords that radiologists use to just make us nuts. And then positive fluid balance, which again, we kind of got that from our exam. She had edema and stuff in her legs. So what new systems come up now? She's got some rheumatologic or immunologic something, and maybe we've got some renal involvement. So now we need to formulate our summary statement or our problem representation. We have to try to tie this all together and to succinctly describe this lady. So my initial problem representation was that she was a 68-year-old woman with asthma, recently diagnosed sarcoma, coming in with acute on chronic dyspnea, an acute progressive purpuric rash with oral and possible ocular involvement, microscopic hematuria with normal renal function, and hypocomplementemia with anti-double-stranded DNA. So let's go into our differential. What does this problem representation make you think of? She's got really bad dyspnea, a rash. Dyspnea, is it COVID? This is an example of one of our heuristics. This is the cognitive bias called the availability bias. And this is when we rely on immediate examples and more recent information to help shape what we think is going on with a patient. Our ability to recall the event means that it must be important, right? COVID is everywhere right now. Is everything that walks into our ER with shortness of breath COVID? Certainly not. We may rule a lot of them out, but we have to be careful with our cognitive heuristics and make sure that we're not putting too much weight and too much emphasis on these diagnoses that come because we've seen them more recently. This can also work in the negative too. We can have more thought about patients that we've had bad encounters with or negative outcomes with. So we might think that everything we see that we had a negative outcome is that diagnosis. So we have to be careful about that. All right, so back to our differential. No, COVID is not on the list. But what is on this list? Well, we've got multi-system involvement. So something is going to be a systemic illness here. We've got pulmonary involvement. We've got potential drugs, skin, GI, eye, rheumatologic, maybe some kidney involvement. So what does that make you think of? Well, it's not going to be a super long list because this has to affect almost every system in the body. So let's start with drugs. Could it be drug-induced lupus? Could it be DRESS? What about pulmonary renal syndromes? She's got a really prominent respiratory complaint. So is it something like EGPA or GPA? And then her purpura just really stand out to me. She had normal platelets, she had normal coags. So if your platelets are clotting normally and you don't have any coagulopathy, how else do you get purpura? Usually when there's a blood vessel problem. So what about vasculitides? Is it something like polyarteritis? Does she have IgA vasculitis, AKA the old HSP? Does she have lupus? Does she have cryoglobulinemia? All these things I think of purpura in my head. So let's look a little bit more closely at some of these diagnoses and see what fits and what doesn't fit. So let's start with the drugs. We always have to blame the medications. Drug-induced lupus. What fits, what doesn't fit? Well, she's on very few medications, which also tells me she's fairly healthy at baseline. And none of them are culprit medications classically for drug-induced lupus. There's no hydralazine or procainamide. There's nothing that jumps out at me. And she has some, but really not many criteria for lupus. So let's move on. Is it DRESS? Okay, drug reaction with eosinophilia and systemic symptoms. Well, she has no EOs. They're not required to make a diagnosis. Well, what else? What about the time course? DRESS takes weeks to develop. She had all these exposures, but they were over the course of a month. That would be pretty atypical for DRESS. And then the organ involvement, the systemic symptoms, she doesn't honestly have that much. I know we highlighted some of these symptoms in some of these organ systems, but as far as abnormalities in the organ systems, I'm not seeing a ton. So I'm gonna move on. What about pulmonary renal syndromes, right? We said she had a significant pulmonary complaint. Well, EGPA, eosinophilic granulomatosis with polyangiitis, you have to have eosinophils for that. She does not. There was 0.0 EOs on her differential. And also her ANCAs were negative, though those are only present in about 40% of these patients. So the lack of EOs, I'm not convinced. What about GPA, or granulomatosis with polyangiitis? These cases really should have ANCAs. They are present in more than 80% of the patients. And hers was negative, so I'm less convinced. Also, her predominant lung symptoms were really this respiratory failure, this hypercarbic CO2 retention respiratory failure, not classic pulmonary hemorrhage, which is what we see often in GPA. So I'm gonna move on from these two. Now, let's talk about the vasculitides. So, polyarteritis nodosa. What fits, what doesn't fit? Well, she's certainly not your typical person that would get it. Usually that's someone that's a man in their 30s or 40s. That's not her. The constitutional symptoms that you often get with these: fevers, night sweats, weight loss, she also doesn't really have. Could you have abdominal pain with this? Yes, that's kind of one of the reasons I put this on my differential initially. So how do we make this diagnosis? Luckily, it's a rheumatology thing. So we've got some criteria, thank goodness. So according to the 1990 ACR criteria, you have to have 3 out of 10 of the things on this list. Spoiler alert, she does not have the first 8. So we don't really have a ton of imaging suggesting blood vessel abnormalities. And we definitely don't have a biopsy, that would be too easy. But even if she had those 2, it would still only be 2 out of 10. And the 3 out of 10 gives you an 80% sensitivity. So I'm gonna move on from polyarteritis. What about Iga Vasculitis, the formerly known as HSP, but we had to change everybody's names. So luckily this has been recently looked at. And in this study, a group in Slovenia got together and looked at, it was over 350 patients. And they were comparing the 2 different criteria for the diagnosis of IgA in adults, because normally we think of this HSP in children. So the ACR criteria are on the left and the Euler criteria are on the right. I want to draw your attention to the Euler criteria, which at the bottom of that screen says it has 100% sensitivity, which is fantastic. None of our tests are that good. And a specificity of 87%, so that's kind of awesome. So how do you fulfill this? Purpura, check. And one of the 4 of the following: abdominal pain, okay, she had some abdominal complaints. Arthritis now, renal involvement, what does that mean? Renal, okay, she's got some hematuria, sure, we'll call that too. And leukocytoclastic vasculitis, we don't have these biopsies. Again, I would love a biopsy right now, but we don't have that. But she does meet at least 2 of those 4. So according to this, she could have Iga Vasculitis. All right, what else? Lupus. It's not a CPC unless you have lupus on your differential. I don't have syphilis on the differential, but it's what is lupus? So how do we diagnose this? This past year, both the ACR and the EULAR, the European Rheumatologic Associations, got together. Obviously, all these people, huge undertaking to reclassify lupus and how you diagnose this. And what did they do? So this was an international initiative. There was 4 phases to this study. The first phase, they evaluated use of the ANA as an entry criteria. Then they came up with all these other criteria. They validated them. I'm not going to go too much into the rest of the study. But importantly, they looked at ANA as an entry criteria. And how did they do that? They took a meta-analysis or a systematic review of over 13,000 patients with lupus and found out that there's a sensitivity of approximately 98% for the ANA. So that brings us to, how do we use this as a diagnostic tool? Well, the entry criteria, you have to have an ANA of at least 1 to 80 or greater. And if it's not there, you do not call it lupus. You stop, you do not pass go. All right, well, this came out last year. What if the CPC was before that? What if we saw this patient 2 years ago? What if we ignore that part and say that the old criteria didn't have ANA as a slam dunk that you had to have it? So let's look at some of these things. Would she meet it? Okay, she has oral ulcers. And could we call this rash a lupus rash? What I remember from Dr. Rubenstein's lectures in residency, pretty much anything can look like lupus. So I'm gonna call it. We're gonna say, sure, this rash could be lupus. And she has this positive double-stranded DNA. So that gives a score of 12, and you only have to have a score of 10 to call it lupus. But there's that stupid brain again. So confirmation bias is at play here. This is when we favor information that confirms our beliefs. I want to believe that this woman has lupus. So I'm just gonna ignore things that don't make sense, like her negative ANA, and look for proof to back up my belief. That's not okay all the time because we make errors when we do that. So I'm gonna move on because she had a negative ANA. Now, what about this cryoglobulinemia? We always think of purpuric rashes with cryo. So how do you make that diagnosis? Well, this, again, there's luckily criteria for all these things, thank goodness. So it involves three parts. There's a questionnaire, there's some clinical criteria, and there's lab criteria. And you have to have at least 2 of the 3 big categories. So the questionnaire items, maybe she meets, she's got these red spots, maybe they're a little brownish, sort of. I mean, they kind of look like that in the picture. Maybe she met that one. What about the clinical items? She has some constitutional symptoms, and she has purpura, but you have to have 3 out of the 4. She actually doesn't meet any of the other criteria. And then the lab items, a low C4, got that, but serum rheumatoid factor, serum M proteins, we have a normal protein, she just doesn't meet that either. So my preliminary diagnosis at the end of my fast thinking was a vasculitis and was IgA vasculitis, or the old HSP. So let's rewind, let's go back. And let's think about this again. We need to go back through this entire case and do it really slowly. We're gonna be in the turtle mode now and make sure we didn't make any mistakes and make sure that our pattern recognition wasn't faulty. So let's start from the beginning. And again, I'm not gonna read all this to you, but we've been halfway through the CPC and there's not been a timeline yet. So let's go through this lady's chronology of present illness in a visual format. So what led up to her getting admitted with respiratory distress? Well, 3 months ago, she had this chills, fatigue, became lightheaded, and had dyspnea. She must not have felt too bad because she didn't present really for about a month. She was diagnosed with asthma, given some medications, and then also at the same time, we saw the mouth sores, the odynophagia, the abdominal pain, the loose stools, the poor appetite, and the early satiety. Then, about a week prior to presenting, her dyspnea recurred. She had a dry cough this time, got some more antibiotics. And unfortunately, 3 days before coming in, the significant rash developed and spread pretty quickly. And then all of a sudden, she's in massive respiratory distress and ends up intubated. Throughout this whole course, she was diagnosed with the spindle cell sarcoma somewhere along here. I don't exactly know where, but I feel like this is really important. It's a massive tumor in her abdomen, as we saw in the images. And this is not a common diagnosis. So I feel like this has to be relevant. What systems are involved here? The same that we found before. So, okay, we didn't make any major mistakes. We have pulmonary, drugs, skin, and GI involvement. So let's go through her exam again, and I want to highlight some things that stood out a little bit more when I went through this a second or third or fourth time. So her eyes. She had edema, erythema, and hardening of her eyelids. That sounds really bad. Could it be a heliotrope rash? I wish I had pictures of her eyes. We couldn't see that. Could it be blepharitis, which is actually kind of a more benign thing, just chronic dry eyes and chronic irritation? Her conjunctiva were injected, and she had anacteric sclera. Okay, so that's helpful despite this massive liver thing. Her pupils were okay. Her cornea, punctate epithelial defects. That sounds really crazy. But actually, when you look that up, it could just mean dry eyes. And importantly, she had a normal fundoscopic exam. The mouth, this hemorrhagic crusting and ulcerations and discoloration of her lower lips, that really stood out to me. That is a pretty unique descriptor for a rash on someone's mouth. And then she had these erosions in her buccal mucosa as well. So this is a pretty weird descriptor. What happens when you look up what causes that? There's not that many things, actually. So erythema multiforme is like the number 1, 2, 3, 4, and 5 thing that comes up. Along with HSV, maybe not. It could just be an erythema multiforme rash. Stevens-Johnson syndrome is another big one. And bullous pemphigoid and pemphigus vulgaris. Also pretty rare diagnoses that come up for this hemorrhagic crusting. So let's tuck that away. And then I really want to highlight some of the important negatives here. She had no fever, no complaints of fever, and no documented fever. She had a completely normal lymph, musculoskeletal, and neurologic exam. So we said she had multi-system disorder, but there are several systems that are actually functioning just fine. And then this leg edema, she had no other signs of volume overload. There was no S3 on her exam. There was no JVD. There was no ascites. Could this leg edema just be more related to whatever rash is going on? All right, so let's look at this rash a little bit more closely. The distribution, I think, is really interesting. So we see that it's pretty highlighted along her knees, which is an extensor surface, and it spares her ankles very interestingly. And then it's kind of scattered throughout. There also looks like things are in a little bit different phases, different forms. Some are smaller areas, some are confluent, some look like you can touch them, that they're papular, and some look like maybe they're just on the skin and more of a macular. So we've got kind of a multiphasic rash here with some extensor favorability maybe. All right, let's go through the labs one more time. So what stood out on second look at the labs? Well, her bicarb's still high, but she importantly has normal renal function. Her BUN's a little high, but she does have normal creatinine. So on the CPC with differential, still no anemia. There's the kind of this left shift, and she has lymphopenia. Is it reactive? Possibly, but something to note. Her hepatic panel, I didn't really find anything too different. I really think all the findings that we're seeing there are probably just from this massive cancer that she has. And then her urinalysis, I put 3 pluses at the blood. She has greater than 100 RBCs and actually small protein, which doesn't quite go along together. Normally when you see a lot of blood and cells in there, you expect to see a lot of protein, or at least you would if this was a nephritic or nephrotic process. We don't really see that. The rest of her chemistries, so importantly now I noticed that we have a completely normal CK going along with our normal musculoskeletal exam. She's Hep B immune and Hep C negative. This positive double-stranded DNA, I don't know what to do with. She has a negative ANA. There's low complement, and her ANCAs are negative. Coags are normal, no new insights there. And if you actually do the math, I will spare you, but if you do the math, she has an acute on chronic respiratory acidosis, not just an acute respiratory acidosis. And importantly, her HSV testing was negative of those oral lesions that we said could be erythema multiforme plus or minus HSV. Nothing new on the imaging, only to say that this mosaic attenuation keeps popping out in my head. And Avi did a great job explaining to us better than I can what mosaic attenuation is, but my takeaway was that there's kind of 3 things that it could be: small airway disease, vascular disease, or parenchymal disease. And he did a really great job highlighting that it seems like it's more favored of small airway disease, or often seen with bronchiolitis. So file that away. Now let's try and summarize this woman again. And I want you to notice the difference in my problem representation here, because I think this was key in highlighting some different diagnoses for me. So now, my new synthesis of this woman with everything we just talked about is that she's a 68-year-old woman with asthma, presenting with intermittent dyspnea, subacute oral ulcers with odynophagia, an acute progressive purpuric rash with hemorrhagic crusting of her mouth, with subsequent development of profound hypercarbic respiratory failure, all in the setting of this recently diagnosed liver sarcoma. So how do I formulate a new differential for this? Well, I'll probably combine things from my initial thinking and then my slowed down thinking into this sort of hybrid diagnostic criteria or diagnostic list that really highlights the key features of this case as outlined in this new problem representation. So there's not that many things when you start looking into all of these symptoms and signs together to put on this differential list. But what I came up with was this IgA vasculitis from before, but is it a paraneoplastic IgA vasculitis? Because this spindle cell sarcoma, I can't get away from this. Is it a paraneoplastic amyopathic dermatomyositis? We'll get to that. Or is it paraneoplastic pemphigus? Again, I said this list is not very long. There's not that many things that will give you all of these symptoms. So let's start with the top. So let's revisit this IgA vasculitis. We already said she met all the criteria, right? She checked off the box, 100% sensitivity. Okay, but what about the respiratory failure? Does that happen that much in IgA vasculitis? Not so much. So maybe that was just her asthma, right? She has underlying asthma. Maybe she had a really bad asthma exacerbation and this IgA vasculitis at the same time. Her complements were a little low, which actually is atypical for an IgA vasculitis case. And then the lip findings are really not that commonly seen with the HSP. But here comes another cognitive bias. So this is the conjunction rule. This is basically Occam's razor. It is much more likely to have one unifying diagnosis than multiple diagnoses. AKA she doesn't have Iga Vasculitis and also an asthma exacerbation and something else that happened to her lips all at the same time. It's just statistically not that likely. So again, go back to our problem representation. We have to keep revisiting what we think is a summary of this patient. The ulcers fit, the purpuric rash fits. It could be perineoplastic, it's been reported, but the mouth findings and this respiratory failure really don't fit. So we should look at something else. All right, what about this perineoplastic amyopathic dermatomyositis? What is that? It's basically dermatomyositis minus the muscle stuff, which doesn't leave that much left other than the rash. So according to the 1993 criteria to diagnose this, basically, number one, you have to have the rash that fits with dermatomyositis, which is basically a heliotrope rash. That's enough to call it. I wish I could have seen this lady's eyes. Could her rash have been a heliotrope rash? Maybe. I didn't get pictures of her hands either, but you would have had to have a rash on the PIP or MCP joints that could also fit this. And then you have to have no muscle symptoms. You have to have no weakness. She had a very normal muscle exam. You have to have normal muscle enzyme levels, and her CK level was completely normal. And then your skin biopsy would have to be consistent with dermatomyositis. Again, I really wish I had a biopsy here. So moving on to our, does this fit with this problem representation? Oral ulcers can be seen. Can you get a rash? Of course. The hypercarbic respiratory failure, interestingly, you can get interstitial lung disease with dermatomyositis. So that fits this time. Can it be perineoplastic? Yes, it has absolutely been reported. But the mouth rash doesn't quite fit either. And I don't know why I'm hanging my hat on this mouth rash, but it doesn't fit. It doesn't fit. So last diagnosis, perineoplastic pemphigus. Never heard of this before I looked this up. It was only described 30 years ago. The most common cause of death for patients that have perineoplastic pemphigus is actually bronchiolitis obliterans. And it happens in 30% of people. The most common perineoplastic or cancers that are associated with this phenomenon are often hematopoietic malignancies like CLL and Waldenstrom's, but it's definitely been reported in thymomas, carcinomas, sarcomas, and Castleman's disease. The skin manifestations, one of the highlights of this disease that I thought was really interesting is that they're so variable. When I heard pemphigus, I was like, well, this doesn't quite fit that erosions, that negative, she has a negative Nikolsky that doesn't look like pemphigus vulgaris that I normally think of. But you can have bullae, you can have lichenoid manifestations, or it can look like erythema multiforme. And conjunctival involvement is common. She had those punctate inferior epithelial defects. Was that involvement of her rash in her eyes? And then on biopsy, again, the biopsy is killing me. You find IgD in the epidermis, and then complement is involved in deposition here. So does this diagnosis fit our problem representation? So she presents with dyspnea, yes. We have oral ulcers with odynophagia, and you can absolutely have that with this. You get significant mucosal involvement. You can have this progressive rash with hemorrhagic crusting of the mouth, completely consistent with an EM-like presentation. Hypercarbic respiratory failure, bronchiolitis obliterans, we have mosaic attenuation, evidence of small airway disease and possibly bronchiolitis on our imaging. And this absolutely is a perineoplastic that can be associated with sarcoma. So moving into the final diagnosis, no, what happened now? Another brain. This is the overconfidence bias. So do I now have an inflated opinion of my diagnostic ability because I was invited to CPC? Very possible. And this is we see this overconfidence bias when we have really unreliable or inaccurate exams, or in my case, inadequate derm knowledge. So with all that said, my final diagnosis is perineoplastic pemphigus, but I really want a skin biopsy to help, and I need some help from a dermatologist ideally, so hopefully they can help.
Thank you, Dr. Johnson. I'm going to go ahead and invite our expert consultant, Dr. Newton, our dermatology hospitalist, that may be able to help Dr. Johnson with some of that. So I'm going to go ahead and invite Dr. Newton.
Thank you. Myself. Hello? Can everybody hear me?
We can hear you, Dr. Newton.
Okay, I'm trying to share my screen. Well, that was a great job, Danny, going through your thinking of patient symptomatology. And good afternoon, everybody. I currently wear the hat of dermatology hospitalist, and I followed this patient very closely from her day of admission to the day she unfortunately passed away. So I'm going to talk a little bit more about paraneoplastic pemphigus here. It's a very rare autoimmune blistering disease of the skin and mucous membranes. It was first described by Anhalt in 1990. In 2001, Nugent et al. Suggested the term paraneoplastic autoimmune. Sorry, can everybody see this right now?
We can't, it does not seem to be projecting the slideshow.
Okay. All right, let me try this again. Nothing yet?
Maybe if you press enable editing, that'll
Okay.
allow it to go.
Okay, let me try that. Sorry, hold on.
Dr. Newton, if it's not going to pull up, feel free to just discuss, and that's totally appropriate as well. Thank you.
Okay, sorry about that. Just a second, let me try one last time and see. Does this work or not?
That looks perfect. Thank you.
Okay, sorry about that. All right, so paraneoplastic pemphigus is a rare autoimmune blistering disease. It affects the skin and the mucous membrane, first described by Anhalt in 1990. In 2001, UN actually suggested the term paraneoplastic autoimmune multi-organ syndrome because several other organs are also affected and autoantibodies bind to several tissues. Usually seen in patients aged between 45 and 70, affects males and females equally. And about 84% of all PNP is found in association with hematologic neoplasm or hematologic disorders. And usually the neoplasm is detected before the onset of PNP, but in about 30% of the cases, PNP may be the first diagnosis before the underlying neoplasm is detected. Moving on, the pathogenesis. So what causes paraneoplastic pemphigus? There have been multiple autoantibodies that have been discovered recently that is associated with the development of paraneoplastic pemphigus. None of them are actually very pathognomonic, but there are autoantibodies against the 210 kilodantal envoplakin, basically the whole plakin family, which is present in the skin and mucous membrane, the envoplakin, the periplakin, desmoplakins, the plectins, and the BP antigen. Also autoantibodies against plakophilin 3, desmocolin 1 and 3, desmoglein 1 and desmoglein 3, and autoantibody against protease inhibitor alpha-2 macroglobulin like 1. Also very important to note, desmoglein 1, desmoglein 3, desmocolins are also described in other kinds of pemphigus like pemphigus vulgaris and pemphigus foliaceus, making the diagnosis a little bit more confused, less straightforward than we would hope it would be. Cell-mediated factors also play a very important role, especially the presence of selective epidermal activated CD8 plus T cells are seen in PNP, and MHC restricted CD8 plus cytotoxic T cells and non-MHC restricted CD56 plus and CD68 plus NK cells are also seen in this disorder. There is a criteria described by Anhalt for the diagnosis of PNP. The clinical features are painful mucosal erosions with or without a multiform skin eruption, which can have blisters, erosions. It occurs in association with an occult or evident neoplasm. The pathology, the skin pathology shows suprabasal intraepithelial acantholysis, interface dermatitis, and keratinocyte necrosis. DIF is extremely important. When you do a skin biopsy under DIF, you see combined presence of IgG and complement granular linear deposition along the epidermal intercellular spaces and also along the basement membrane zone. Again, you can see all of these features in various other skin conditions too, but very importantly, in indirect immunofluorescence, you see circulating antibodies against the intercellular zone of stratified squamous or transitional epithelia. And immunoprecipitation shows a complex of proteins, including desmoclein, desmoplakin 1, BP antigen, and other proteins that were described earlier. This is just to show you how different polymorphous the skin lesions can be. Over here, this looks more like something that you would see with pemphigus vulgaris, with the erosions and the Nikolsky sign positivity. Here is a patient's dorsal arm with more lichenoid presentation of the skin lesions. And this photo shows EM targetoid lesions presenting as PNP, and over here more bullous lesions with erosions. Now, how do we manage? Management is extremely difficult. High-dose corticosteroids are still considered as first-line therapy, but steroids only improve the skin lesion, while mucosal involvement is very refractory to treatment. Combination of steroids with other drugs such as azathioprine, cyclosporin, mycophenolate, cyclophosphamide, and IVIG with plasmapheresis. Well, basically, when we don't have one exact treatment for a disease, it means that we really don't know how to treat the disease effectively. Some newer therapies include rituximab, which is an anti-CD20 monoclonal antibody. And to take care of the cell-mediated immunity, people have tried alemtuzumab, which is a monoclonal antibody against CD52. And this has helped in inducing remissions in some of the patients. Prognosis is generally very poor, 90% mortality rate, and death is usually because of the underlying bronchiolitis obliterans, GI bleed, sepsis. Interestingly, sometimes PNP and underlying malignancy do not have a parallel evolution. Now, I do have some more pictures of the patient that we talked about. So if you look at her skin lesions, it's really very polymorphous, and it varied over her time course in the hospital. I think that's a very important distinction when it comes to skin lesions. Not all skin lesions look the same over the course of their life, especially in paraneoplastic pemphigus. You see lesions appearing and disappearing over the course of the disease process. So here, you really don't see any purpura in any of these pictures. This is her back. There is pretty much 100% involvement of her body surface area. You see multiple erythematous papules. And this is her hands. You see more lichenoid infiltration of her hands. The plantar surfaces of her feet are erythematous and inflamed as well. And I think this was a photo that was already put out. If you look at her oral mucosa, there is definitely buccal involvement of her mucosa, and also her lips, you can see the crusting and the ulceration. And her palms also show a lot of erythema. This was on the day of her admission. Now, as she progressed during her disease, you can appreciate bullae now. So basically, she initially had papules, and then 1 week into her disease process, she started developing bullae, which did show Nikolsky positive D sign. She developed that on her back, she developed that on her face, and this is a little bit of her eyelids that you can see. They were very swollen, and there is no heliotrope trope rash that we were thinking about. All right, so coming to her skin biopsy, this is a low, this is her low power skin biopsy. You can see numerous dyskeratotic keratinocytes, basically, which means that even on her basal layer, you can see keratinization process starting. This eosinophilic material that you see near the basal cell, that is dyskeratotic keratinocytes. And this you can see in many other skin conditions too. And a lichenoid infiltration, which is an interface, kind of interface dermatitis that you see at the epidermodermal junction, and suprabasal clefting, where the skin has started to break away from the epidermis and the dermis have started to split away. The high power actually shows acantholysis. Acantholysis is a process where the epithelial cells start breaking away from each other. They start, the cement that's holding the epithelial cells start dissolving. And this is basically because of all the antibodies that we described before. And that's all I have. Be happy to take any questions.
Wonderful. Thank you so much. I'm going to open the floor now, and we're going to invite the audience to use the, and congratulations to Dr. Johnson on a correct diagnosis. We are going to open the floor now, ideally using the Q&A portion of this webinar feature to either Dr. Johnson or Dr. Palutla or Dr. Newton. And I do see a question, and it looks like this is Dr. Nandan asking the question: is the lung pathology autoantibody mediated in this disorder? And if so, what autoantibody? Would there be a role for Plex in this disorder? I'm assuming that's for Dr. Newton.
Yes, yes, yes. So basically the plaquin antibodies are also present on the mucous membrane, and that is involved when you do a lung biopsy. And Plex has been tried in this disorder. But it's really important to get the underlying malignancy treated first.
Thank you. We have a brief moment for any other questions. I'll give folks time to type into the Q&A. All right. Thank you all very much again. And to Dr. Johnson.
Thank you, Dr. Johnson.